What most of the research has looked at is exercise during cancer treatment and following cancer treatment in a totally outpatient model. So if we intervene with activity during chemotherapy or afterwards, does it improve outcome? So this was a meta-analysis I again did with my colleague at the University of Alberta, where we looked at all the studies that have been done in breast cancer only that were randomized controlled trials. And we wanted to look at what the outcomes were with exercise interventions. So this is a busy slide that sort of talks about what the studies actually looked like. In the original publication, there's only 14 studies, and we updated this for the World Congress of Physical Therapy. I think it was in 2008 that was here in Vancouver. So the total analysis today is with the 20 studies. A lot of the studies were supervised activity, some are home-based, and there's a variety of interventions. So a lot of aerobic, and some that were aerobic and resistance combined, so sort of a circuit training approach. There was one study that had an aerobic arm, a resistance arm, and usual care. So that's what aerobic versus resistance is. And one looked at Tai Chi versus usual lifestyle. The prescriptions were quite a variety as well. 7 to 26 weeks was the length of the interventions. The sessions per week were varied. The prescription in the aerobic was mostly related to maximum heart rate, either estimated or measured. And with the resistance, 1 repetition max test or an estimated 1 repetition max, or no real anchor for initial values. The one thing we also looked at too was adverse events, because safety always is an issue with exercise. We wanted to ensure that that wasn't an issue. Back injury was the most common across the 1,300 people that were made up these studies, and there was some cases of lymphedema, but certainly not more than usual population prevalences in this group. So in terms of what we saw, we were able to look at, was the exercise during treatment or following treatment? Because that seems to make a big difference. The sort of minus mark means no real difference, and the plus is a benefit. So for quality of life, we saw no real change if the exercise was during treatment, but a big improvement if the exercise was done following treatment. That was similar for physical function as well, close to the bottom, as well as for fatigue. We didn't see too much change in weight or body mass index. None of these studies were really designed for weight loss or changing body composition, so we're not too surprised there. And for aerobic fitness, there weren't enough studies for us to divide it. So overall, there was an improvement in aerobic fitness, but we couldn't divide by time of treatment. I think the main take-home point we think from these results is that you may want to tailor your expectations for the intervention and prescribe activity differently depending on what time frame you're working with. If during treatment, the goal is really to maintain physical function, maintain quality of life. Typically in the studies that have looked at people over time, those that are active tend to maintain their physical function, whereas those in the control group slowly drop off. So if you can maintain your physical function, you're doing very well. Following treatment, you may want to just be a bit more ambitious and want to improve physical function. So prescribe your activity based on that as well. Also, too, there is a large meta-analysis that came out just this year that looked at all cancer types. So not just breast cancer, but all the different cancer types. And they did randomized control trials and just interventions that weren't randomized. And this is a snapshot of what their study characteristics looked like for them. The majority were actually done during treatment, so only after treatment. Only 40% were done during cancer treatment. Breast cancer were the majority of studies still. Those are the top 5 there, and you can see it drops off precipitously after breast cancer. A lot of this research has been done in breast cancer survivors. They're one of the largest breast survivor groups, and they're a little bit more homogeneous potentially in terms of their demographics and the kind of treatment they get, so they have been overstudied definitely. Also, too, this meta-analysis tried to break it down into those based on that framework that I showed you originally to show you where the studies are really being done. There's one study on buffering, which you can see makes that little slice of the pie in the orange. The majority were coping, so that would be during, not the majority, but a big chunk were during chemotherapy treatment and helping to cope with treatment. A majority were done in rehabilitation, so after treatment, really focusing on some deficits. There was a big chunk in health promotion, so sort of improving health and quality of life after cancer treatment. Survival a little bit, and that's mostly looked at interventions and changing biomarkers related to cancer risk, so nothing like pure solid outcomes. And palliation, you can't really see. I don't know why PowerPoint picks these colors, but it does. It's not even on the pie. So there's been no studies in palliation and exercise. But what they found, this is a snapshot of a paper that has 2 full pages of tiny type outcomes. So if you have a favorite outcome that you're interested in, they have looked at it in this paper. I just picked out the physical activity that just for the interest of being able to read it. So for physical activity level, how active were you before and after treatment? What they looked at is the quantity of evidence. So how many studies looked at that? Was there a positive effect? And then they tried to see whether that positive effect was actually statistically significant. These are all during treatment. They've also broken it out into after treatment as well, which I'm not presenting. You can see there that overall there was a positive improvement in a lot of these outcomes of physical function. But when you start to look at whether they were statistically significant, there was a bit of a drop-off. And I think that's similar to what we found. It's positive, but they're potentially during treatment, you're not seeing huge gains. You can see with the objective measures of physical activity, there was only one study that actually looked at this. So that's a pedometer or something along those lines. So there's probably a lot of room to use some objective measurement tools in this population as well. And certainly I just listed some of the other outcomes: quality of life, fatigue, depression, anxiety, sleep. They've got it all in there. So you could look at that if you're interested in some other outcomes. The point I think that has sort of been left behind in these meta-analyses is what is the quality of the actual intervention that was prescribed? And that hasn't been looked at in the meta-analyses. They looked at the outcome, but when we recently, with one of my graduate students and a collaborator at the OHSU in Oregon, we've looked at what was the actual prescription? How well did they document that? And how well did they use the training principles to actually come up with the intervention in the first place? This slide is attempting to show what was actually reported in the methods of how they developed their intervention. FIT method, of course, is if anyone puts on their human kinetics hat, is frequency, intensity, type, and time, how we normally prescribe activity. And you can see that majority did report that these FIT principles. They outlined what the intervention was going to look like from all these dimensions. But some, their one study didn't report any frequency, 6 didn't report really intensity, and 5 didn't report any amount of time. So there's sort of these prescriptions that leave out these things, which would be really hard to replicate some of this research because we don't know exactly what people were doing. I won't show you the graph for the results, but you can imagine it's even worse than this. People don't report a lot of this information in the results. So ideally, they were planning this, which wasn't ideal in the first place, and at the end, they don't report hardly any of it, and so we don't know what happened. And also, too, we got very geeky, but not quite as geeky as I don't think we required the hats for this. We looked at the different training principles, and we wanted to see how well those were used. We've used a plus, means that they reported it. A question mark, meaning we don't know exactly what happened. They made some mention of it, but we're not sure. The X meant that they talked about it, but they sort of applied it incorrectly. And of course, that's our judgment on incorrectly, but it was our attempt to get at that. And you can see the gray bar is not reported. Specificity just means if you're trying to prescribe the activity, it's actually going to have an impact on the thing you're actually trying. So if I want to improve my aerobic fitness, I don't start doing bicep curls. That's what specificity is. Progression talks about having to make it progressive over time. You always have to change if you want to have adaptation. Overload, again, similar sort of thing. Are we changing the prescription? Are we overloading? Initial values, I think, is really interesting. Did you actually do some sort of objective measure to figure out where the person was at beforehand? So when you prescribe the activity, it is going to be either challenging enough for adaptation or not too challenging that they'll get fed up with it in the first place or they're overtrained. And the diminishing returns and reversibility just means that if you stop the exercise or didn't change it, do you see a decrease in that in the fitness? Not many people have done this, and that would be a 6-month follow-up after the intervention. So I guess it's not that strange that they haven't done it. But the main point here is, I think, from this literature, the big problem we are left with is how can we replicate these interventions if we don't know exactly what's been done? And then are we really achieving the most effective interventions possible for cancer survivors if we're not using these training principles, if we're not using initial values? Maybe the exercise is even more beneficial than we know without having that information to start with. A lot of the prescriptions have been a bit more generic just because we don't know a lot, but it makes it difficult to come up with guidelines when we don't know exactly what's happened with the research. I just want to focus here on some emerging areas of research as we finish up this presentation. As Linda mentioned, we are looking at cognitive function. So can exercise improve? Chemo brain is how it's described sort of as its nickname, but some people report changes in cognitive function following chemotherapy, just processing, being able to remember, recall. And so we're looking at whether exercise can change that with a group in the Department of Physical Therapy that do a lot of cognitive function. Arthralgias are an emerging area as well. Just joint pain, muscle pain. There's a trial called RAY. I don't know what it stands for. Looking at this in individuals who, we have some RAY participants and RAY trainers in the audience, as it looks like. Some of the hormonal treatments that are current, the aromatase inhibitors used in breast cancer survivors are causing these arthralgias. They don't really know the underlying cause, and so can exercise help with this? We don't know, potentially, and hopefully yes, but there's a trial underway at the BC Cancer Agency looking at this. Neuropathy is a huge area for cancer survivors that's emerging. As cancer treatments are changing, the side effects that are associated are emerging as well. This is really particular for colon cancer survivors and some of the treatments they're using. Neuropathy and basically burning, feelings of pain in particularly the hands and feet. Can exercise help with this? I don't know. I don't know what the mechanism would be for that, but certainly it's an emerging area in cancer survivorship, and potentially exercise could play a role. Fatigue is an ongoing area of interest for cancer survivors. It's an ongoing side effect. My master's student, Sarah Neal, is looking at some physiological measures of this. So if anyone knows breast cancer survivors who are fatigued, please do come and talk to me after. Bone health is an emerging area as well. A lot of the hormonal treatments are decreasing bone density, and so there's a lot of interest in whether exercise could help with bone health in this group, either in combination with the current medicines like bisphosphonates or alone by itself. And also in older adults. The cancer is a disease of older adults to begin with, for majority. And is the cancer treatment that we're giving moving people more towards a frailty phenotype? Are we making these people more frail? And could exercise actually circumvent some of that or help to stave off some of that frailty that comes with treatment? And I just have to highlight one study here, just because it's the new hot topic in cancer survivorship. This is a study that was published in the New England Journal of Medicine, a very prestigious medical journal. The first time a cancer and exercise study has made it into that journal. And this was a study done in individuals who had lymphedema following breast cancer. And they wanted to see that would resistance training increase your risk of lymphedema issues if you already had lymphedema in the first place. So it's a very novel study in moving over a lot of sort of taboos about resistance training in cancer survivors. What they saw, they did a year-long randomized control trial. Everyone had lymphedema to start with, and they randomized them to resistance training or usual lifestyle. There was a similar number of women that had an increase in swelling of the limb between the two groups, so no difference between the groups in increase in swelling. The weightlifting group reported improved severity of their lymphedema symptoms. There was also a lower incidence of lymphedema exacerbations in the group that were doing the resistance training. So 14% of the individuals who were doing the resistance training reported an exacerbation of their lymphedema, and almost 30% in the usual lifestyle care control group reported exacerbation. So the big findings from the study is that not only is it safe, because there were no adverse events, it actually decreased lymphedema flare-up in the individuals who were doing resistance training, which was the exact taboo for breast cancer survivors up until very recently. So a pretty amazing finding. And I think the implications for prescription, if you're starting to think about resistance training in this group, they really focused on a very slow progression of the intervention. So starting very low weight and slowly progress. All individuals were wearing compression sleeves during their resistance training as sort of a prophylactic. There's debate about that, but that's what this group used. And also they did very careful monitoring of swelling in the hand and arm. So if there was any increase, they were immediately sent to a physical therapist to have treatment or just to be monitored and see what was going on. The biggest thing they said, too, is that if people started to miss sessions for vacations and things like that, that they reduced the resistance and had to build up again. So it was very much a very gradual progression, with the idea being that you don't want to startle the lymphedemic lymph system, I think was the general idea.